Good morning and a very warm welcome to today's webinar, Managing Cognitive Change in Multiple Sclerosis. Really delighted today to have two fabulous presenters. We've got Marley Lavav and Jackie Efthimiou, and I'm your facilitator, Nicola Graham. So we like to start our programs with an acknowledgement, and we acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. And we acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and respect the cultural authority of the elders in each community. So our presenters today are both OTs working in the Employment Support Service here at MS. Marley's in Melbourne. She's worked with ESS for 9 years, plenty of experience in neurological conditions, cognitive rehab, mental health and research in Australia and overseas, and Marley's done postgrad study in cognition. And Jackie Efthimiou is in our Lidcombe office in Sydney, although at home like most of us at the moment. And Jackie's worked in a variety of fields, including acute hospital care, stroke rehab, community rehab, paediatrics and education. And again, just a warm welcome. I can see more people joining, so very warm welcome to you all. And we've got a lot of people online today, and we've got a lot of information to get through today. So I'm now going to change screens and hand over to you, Jackie. Thanks, Jackie.
Beautiful. Welcome, everyone. And Nicola's right, we do have a lot of information to get through today. So we've got the objectives and learning outcomes listed there. We will be looking mostly at the strategies around how we can help clients with cognitive impairment. So we've got a video to start with, and before the video starts, we just want you to have a think about how Paula is managing her cognitive change and what sort of words she uses when she describes that change. So Nicola, I'll get you to start the video when you're ready.
I'm Paula and I'm living with multiple sclerosis. I feel like the only time I've experienced the cognition and the problem with cognition and thinking is I probably experienced it first maybe 3 years ago, and it was when I went back into work after 2 years, and it was in a role that I was my first role. I was really passionate about what I was doing, and it wasn't just a job to earn money, and I really wanted to make an impression. And I started to notice that I found it quite difficult to have conversations with people. And I was like, this is really unlike me. I've never had a problem having conversations. And then it was sort of when I was trying to communicate my work, I'd sit in meetings and I came across like I was babbling. And in my head, I just knew that I wasn't saying things as clearly as I should or I have done in the past. And that's kind of where I had to start making notes. And I was like, this is so unlike me. And at the beginning, I thought maybe that's just me and it's just sort of how I am, and maybe I've always been like that. But it's really been over the past 2 to 3 years where I've experienced brain fog for like quite a long time now, and I can notice it even when I have conversations with my friends. I'm only just about understanding now that it probably is because of my MS. It's a really frustrating one. If you were to see what I write down, I have such like clear thoughts, and I would speak with such conviction if I didn't have this cloud jumbling up the thoughts in my head. It really is like a fog. It's like a literal fog in your brain.
Excellent. So you would have noticed that Paula was describing functional changes in her ability to have conversations and to express herself clearly in work meetings and social events. She also commented on how frustrating those changes were to her. And you could see that she needed to physically read that information from her notes because she couldn't come up with those clear items to discuss as well. So for cognitive change, approximately 2/3 of people with MS experience cognitive impairment as a result of the disease. And for most people, symptoms are relatively mild. They can fluctuate from day to day, and they can be invisible. So hence they often go undetected. Clients may notice small changes and they may feel very vulnerable when discussing their concerns, which is something that we need to keep in our minds as clinicians. When looking at risk factors for the onset and development of cognitive impairment, these can include the disease course. So around 50% of people with RRMS, so relapsing remitting MS, have some type of cognitive impairment, but this rate can actually jump to 80 to 90% amongst people with progressive MS, which is really interesting to consider. Also looking at age, so when you're increasing age, it's an elevated cognitive issues. Sex, personality traits, and health behaviour, as well as genetic factors, will also come up as risk factors too. Most risk factors are not changeable, but we can assist in improving health behaviour, and we'll mention that later on today. Cognitive reserve is a major protective factor in developing cognitive changes. So studies have shown that people with MS who have a higher education and IQ, a greater vocabulary, more hobbies, and participate in activities which stimulate their cognitive abilities, they actually have a higher cognitive reserve. And as therapists, we can encourage our clients to enhance that protective factor by doing things like reading books, taking courses, learning new things, or doing exercise as well. Often people feel their cognitive changes have occurred due to other factors such as fatigue, poor sleep, mood disorders such as anxiety or depression, high levels of stress, or medications which can affect their alertness. It's important to know that all of these things can influence cognition, but they don't actually cause the reduction in cognition with a client. It's important to recognise how some cognitive symptoms may present to others. So you may speak to a client who says that other people comment that they're vague, that they're unreliable, they might call them lazy, cranky, easily distractible. It's also listening to the language used by people when describing their cognition. They're not going to say to us, I have difficulty with my information processing. So this is just a short list of common issues raised by our clients and what domains the issues can be linked with. A lot of our clients will say that they have difficulty with memory, that they're easily distracted, and they have difficulty with multitasking. The Online MS in America 2015 survey gathered insights from nearly 6,000 individuals in the US who have been diagnosed with multiple sclerosis. What they found was the most reported functions that were impaired were memory, information processing, and word finding. It's also important to remember that these would have been self-evaluations gathered by the survey. So most people would say that their memory is impaired when we know it might not be memory that's the issue. It could be the information processing side that is the actual issue. Now, cognitive impairment can impact all areas of a person's life as we use our cognitive domains in every task that we do. So research reports that people with MS with cognitive impairment are less likely to be employed. They engage in fewer social and vocational activities. They have greater difficulties carrying out routine household tasks and are more vulnerable to psychiatric disorders than people with MS who have a purely physical disability. Cognitive changes are one of the main reasons people affected by MS are struggling or choosing to leave work. And a lot of our clients within the MS Employment Support Service relate to this as well. So I completed some what they call brain tree training with an educator named Kit Malia and an OT named Anne Brannigan. And they created this hierarchy of cognition. It's a UK-based training program developed from working with returned soldiers who sustained brain injuries during service. They advise that when considering where to start with assessment or intervention, to use this diagram and to use this hierarchy to basically commence from the bottom and move your way upwards. I found this really useful as a point of where to begin with both assessments and interventions of cognition. So starting at attention and working all the way up to executive functions with a client. So we're going to run a poll, and I'm going to let Nicola run this one for us.
Okay, sorry, Jackie. So how do you know if a client has cognitive issues? So if you can all vote on this, it's anonymous. So go for your life, and please tick all that apply. That would be great. And I can see we're a little bit slow to get voting this morning. Okay, so about 20% of people have voted so far, up to 50%. So I'll just give you a couple more minutes. That's great. People are switching on their brains and getting going, which is fantastic. Okay, just a couple
just
more
while
moments.
we're waiting for them to vote, Nicola, I also wanted to say, when looking at intervention, the client needs to have awareness and insight into the cognitive difficulties. Otherwise, any intervention we provide is going to be ineffective. So this training is now available online to anyone working in cognition, as it covers both assessment and intervention processes. And it's really easy to learn in podcast modules. I actually attended face-to-face, but now with COVID, that's going to be an impossibility of people coming over from the UK. So if you're interested, have a look online for Braintree training.
That sounds great, Jackie. Okay, so just about everybody has voted now, just a couple who haven't. So I'm going to close and share the information that people have voted. So Jackie, can you see that? Do you want to talk us through that?
I cannot see it.
Okay, so 91% of people have said clients' complaints. Additionally, 91% have said own clinical observations, 85% direct questions, informal interview, 66% formal questions and subjective tools, and 83% formal assessments and objective tools.
Great. So everyone's using quite a range of different ways to assess cognition, which is awesome. Awesome to see. Okay. So we're not going to focus on assessment of cognition in this webinar, but we do agree that in order to provide intervention, you need to know how to assess cognition with your clients. You can't provide intervention if you don't know what you're providing intervention for. So observations are the best place to start, and we tend to underestimate this as a part of our assessment. But we need to keep our ears and eyes open to notice any issues coming across. Before deciding on a more formal assessment, you really need to think about the purpose, whether that assessment is going to be beneficial for the client. If you do complete one, please ensure that you discuss both the client's strengths as well as areas for improvement. Try not to just focus on the issues or the concerns that you have from cognition too. Asking open-ended questions during history taking is an important way of gathering information, and a simple question can yield a lot of different information around cognitive processes. You can also select a task to assess the client's cognition in a functional capacity. You might want to use a task that's simple and quick. You may want to use a familiar task to the client, or you may choose a new task to actually test a different component of their cognitive domains. But as therapists, our observation skills are really targeted. So I think we need to utilize that as much as possible and take into account our level of experience in taking those observations on board. So we've put both of these tools in the handouts about the OT approach for evaluating and treating cognitive issues. And that's from the Vancouver Coastal Health. But be mindful that people with MS overreport cognitive changes due to depression and a tendency to attribute all changes to MS. And they also underreport due to reduced insight, shame, or embarrassment or fear. What we've got up here is the MS quality of life inventory, and that has two versions, one for the patient and the other for the informant or the carer. Okay, my favourite man or not, but we won't go into that here. One of the cognitive screening assessments we have been using at the employment support service is the mocker. It's the same one which Trump claims he got 30 out of 30 on, but that's debatable. Looks at short-term memory, visuospatial abilities, executive functions, attention, concentration and working memory, language and orientation to time and place. But be mindful now as it requires training and certification to utilise the mocker. It's also only a screening tool, so it can give you insight into what sort of cognitive domains a client is having trouble with, but it can't give you a diagnosis of what's actually going on. Another short and popular screening test is the SDMT oral version, which is especially useful for people with reduced motor abilities. So it measures information processing speed, and the lower the score is, the greater the cognitive deficit. So there's a link on your notes if you wanted to watch a video on this assessment tool as well, and Marley's used that a couple of times as well. Another option is neuropsych assessments, and they may be appropriate with certain clients. The assessment can assist to target deficits and develop management strategies specific to the individual client. You really need to look at the cost and the time involved in a neuropsych assessment. They're very lengthy, but it can give you that pinpointed idea of where the client's deficits lie, and they can actually give you some really good strategies working towards how you can actually help that client with those deficits. Sometimes a neuropsych assessment is really good as well if a client is demonstrating that they don't have any issues, yet you can clearly see an observation and reports from their carers or loved ones. So it can actually give them some black and white feedback as well about what's going on. So some options for getting to a neuropsychologist: there are private neuropsychs that are available. You can get referrals from your GP or your neurologist, and there are some student clinics through the universities as well that can provide them. They are costly. I've had a couple of clients have funding through their NDIS plans for neuropsych assessments, but that's the rarity of it. Okay, so we're coming up to interventions now. And the first intervention we do, but we don't actually consider an intervention half the time, and that's education. Knowledge is power, and it provides understanding and the link to our interventions. So it's our role as health professionals to help our clients to understand what is happening and assist them to tailor the strategies to suit their needs and preferences. And it's not only education to our clients, it's education to their carers and their families as well as to what's going on. I'm not going to spend a whole heap of time on embracing a brain healthy lifestyle. I think that's a whole webinar in itself, but just some ideas to touch on with clients to ensure they're living a healthy lifestyle, as all of these areas will also impact their cognitive function. Okay, so types of cognitive strategies. There are 5 broad types of how we can provide intervention strategies for clients. The first one is training of specific abilities. So through the use of training exercises and tasks in which the cognitive requirements are gradually increased. So for example, training attention or memory. There's remedial strategies, so focusing on improving metacognition, so increasing the client's awareness by giving them feedback and discussing efficient work strategies. Compensatory strategies, so the use of aids like a diary or a system in place that can set reminders for a client. We could look at adapting the environment, and we could look at task-specific training, so systematic training of routines through repetition and slowly reducing the cues that we provide with a client. So we're going to go to the next poll. We just wanted to see what sort of areas are you guys using your strategies with your clients. So I'll hand that one to Nicola again.
Thanks, Jackie. So just launched that poll, and if you could start voting, that would be terrific. And we've got training of specific abilities, remedial or internal strategies, compensatory or external strategies, environmental adaptations, and training of specific tasks. So just having a look, about 50% of people have voted already, which is great. And I'll just give you a few more moments. And again, just reminding you, it's anonymous. So go for your life.
And there's no right or wrong answer. It's just to see what everyone else is doing.
Beautiful. Okay, I'm going to close that poll now. Thank you everybody for your input, and I'll just share that information. So Jackie, what we've got is 5% of people are doing training of specific abilities. Nobody's doing remedial or internal strategies. 66% compensatory or external strategies, 15% environmental adaptations, and 15% training of specific tasks.
Okay, that's awesome. So a lot of use of aids is what's coming across there, which is the biggest one coming from everyone, which it doesn't surprise me at all. And when looking at Braintree training, they were certainly saying that when we go through our own training as physios, OTs, all of those exercise physiologists, we are taught those compensatory strategies. We're not taught about how to train the specific tasks or the specific abilities. But it all comes together. You can't just focus on one area. It's like trying to teach someone how to tie their shoelaces. You can't just do that off compensatory techniques. You have to get in there hand over hand, giving them different options to work through it. And it's going to depend on your client as well, which is where we come up to the next one. So the clinician needs to determine which cognitive strategies are going to suit the client best. For example, a client with awareness of their deficits, high capacity for new learning, and motivation for self-management, we would focus on internal strategies, getting them to generate ideas for external strategies and adapting the environment as well. But on the other hand, a client with poor insight about their cognitive deficits, who are more reliant on their carers, we would look at working with both the client and their carer, focusing on building the awareness of the deficits, completing training on a specific task, which is important to the client, and assisting the carer to adapt to the environment. As part of the clinical reasoning process, we need to take into consideration factors related to ourselves as clinicians as well, and those are outlined there for you. Okay, brilliant. So here is where I flick over to Marley to look at attention and concentration. Take it away, Marley.
Cool. So thank you so much, Jackie, for a wonderful introduction. So it was really interesting for me to see that actually people are not using any remedial strategies, and I will basically present a mix of strategies as per the domains that Jackie mentioned before, and of course based on what people with MS are actually complaining about. So let's start with attention and concentration. These are actually the building blocks of higher cognitive abilities because they are needed for most of mental activities. And attention concentration really allow us to select and focus on one stimuli, even though there might be competing stimuli, and also switch between stimuli or tasks. And this is what many people with MS and other people find very difficult. This is what's called multitasking, but it really is about switching between tasks. So what people might complain about is that, or what we might see as clinician is that people can't complete all the steps in a complex task, or I have many clients who are saying to me that they can't concentrate in noisy environments and they get easily distracted. If their mind starts wandering, they're really struggling to follow up, to follow a conversation or a TV show or even read a book. So what kind of strategies we can offer our clients? So I think we really need to focus on, first of all, relaxation. When we all focus and stressed, we really can't concentrate. So it's really important that we as clinicians help our clients to feel more relaxed, even if we can help them to identify what kind of relaxation strategies help them in order to prepare to perceive the information. And I would really like to mention here mindfulness meditation that has been shown to be effective in reducing anxiety and actually improving attention, also amongst people with MS. So it's really worthwhile mentioning that. Also, we can help our clients to identify when they are more alert during the day and suggest that they prioritize their task based on how much attention these tasks require. For example, if you've got a client who's more vigilant in the morning, it might be best for them to complete the tasks which require more attention in the morning, and of course afternoon, so it really depends on them. You can also advise your client to divide tasks to smaller steps. This is the chunking. So even if they have a short attention span, they can still accomplish the smaller steps, which help with motivation because they can tick it off, but it also would be a reminder if they lost track of where they were. Also, please try to encourage a client to do one task at a time, because really most of people, regardless of whether they have MS or not, are really not good at multitasking. Short breaks are really, really important for everyone, and of course for people with MS as well. And rather than just saying, yeah, I think you should take a break, really have a discussion about how frequently and how the breaks would look like. So for example, breaks should be, I've read about this, that breaks actually should be the opposite of a typical work environment. And I'm talking about work because I'm working in the MS Employment Support Service. But let's say that a person is working by themselves in a sedentary job. So a good break, for example, would be having a healthy lunch away from the desk, going out for a walk outdoors, of course, while maintaining physical distancing, with a colleague and talking about non-work related stuff. So this is a really good break as a mental break. About environmental adaptation, so removing distractions, really the ideal environment for enhanced attention is one with minimal or no distractions. So really you can talk with your clients about how they can remove distractions, such as organizing the desk or their environment, turning off email or phone notifications, TV, radio. If they need to write a very important report, schedule a private room to do that, and maybe meet with friends in quieter areas or one-on-one rather than in large groups. I've got many clients that really find the use of noise cancelling headphones really, really helpful, especially when they work in open plan offices. And I've got some clients who really use alarms and reminders because they tend to sit, for example, for a long period of time and don't really remember to take a break. So alarms and reminders can be very helpful to remind them to take a break. Let's move on to processing speed, information speed. So really, we are constantly required to process information that we get from the environment, and we can only process a certain amount of information at a time. Now, many people with MS can feel overloaded if too much information is coming in all at once, or if the information is coming in too quickly for them. So they may not be able to keep up with conversations, or they may need more time to complete tasks, solve problems, making decisions. And memory problems, as Jackie mentioned before, may be related actually to the information processing speed, because the person can't keep up with the flow of the information coming in, or maybe the information was never processed from the first place, and this is why it can't be retrieved from memory. So what can we do as clinicians? So I've got lots of clients who complain that they are slower, and they become very frustrated with themselves and even being very harsh and angry at themselves. So really what I try to tell them is, be patient with yourself, be kind to yourself, give yourself more time to take in the information, because that's actually going to help you. So I would like to demonstrate some examples of the strategies I mentioned here. So one of my clients, she has a really good awareness of her reduced processing speed. So when she has an appointment with her neurologist, she basically books a longer appointment. She tends to ask a neurologist questions, which helps her to actually process the information. Another client of mine, she tends to meet with her manager at the beginning of each day to discuss work priorities. However, the manager tends to talk really, really quickly. So my client asked the manager to slow down. Then she repeats the information back to the manager in her own words. And she also takes some notes, like short dot points, which you can refer back to during the workday. So these are obviously the compensatory strategies. I have some clients that tend to ask me about brain training programs. This is the computerized cognitive training that's mentioned here. I tell them that studies really show that some brain training programs can be effective in improving attention, processing speed, executive functions, and memory, and we've mentioned a few articles. But it is really important to remember that usually these programs require a high level of motivation, self-discipline, and commitment. Usually the person do them by themselves at home, and it does require lots of engagement, at least 4 or 5 days a week for half an hour. So many people really don't have this kind of can't really commit to that if they're working full-time, have family commitments as well. So it's really important to make sure that it actually might not be suitable for them. Very interestingly, a pilot study that compared the efficacy of brain training programs to mindfulness meditation actually found that mindfulness meditation was actually better at improving processing speed. So this is really important to notice. We also mentioned that in attention. Next to verbal fluency, so this is what Jackie mentioned in relation to word finding. So these are very, very common amongst people with MS. It can be highly frustrating knowing what you want to say, but you really can't find the right words. Obviously, it affects verbal communication, and we usually see it in people who have slow speed of processing. So it may take them longer to find the right words, and I'm trying to actually encourage my clients, again, not getting frustrated with themselves and not telling themselves that they're stupid or idiots, like just take some time, have a deep breath, and basically we move on to the intervention. So as we mentioned in attention, feeling relaxed is really, really important. And then let go of the conscious search of the word, because the brain will continue doing the search subconsciously. And of course, people do this already. They try to use synonyms. And if they do have some time, you can actually ask them, so how did the word sound like? Do you remember what it started with? What type of letter? What was the meaning? Can you visualize that? And sometimes it will come up, sometimes it won't, or sometimes it will come up later on the conversation, which is fine. You can also tell your client that it is better to aim for conversations in person and in place without distractions, really very similar to what we spoke about in attention. And I'll give you an example of a client of mine. She gets very anxious when she needs to present in front of her colleagues at work. She can't find the right words. She stutters, she gets very embarrassed, and she is very aware that her anxiety makes things worse for her. So we discussed a few strategies. She's doing yoga for many, many years. So actually what she does, she starts with relaxation by taking a few deep breaths before she's actually presenting. She's also using key written keywords to remind her of what she's going to talk about before during the presentation. And she practices, obviously, before the presentation, as repetition also helps her to feel prepared and more confident in her abilities. I won't spend so much time on the visuospatial function, but just a few things here to remember. This is basically the capacity to relate visual information to the space around us, and it helps us to find our way and allows us to judge distances between our body and the doorways, for example, when we're walking, or between cars when we're actually driving. And I've had a few clients that basically told me that they tend to bump into doorways when walking, even when their balance is intact. And people, and I think this is really important, especially for the physiotherapists and exercise physiologists who are attending this webinar, to keep that in mind as well. Other people might find it difficult to find an object in a cluttered environment. And recently I've had a client who told me that she thinks she became dyslexic because she reads some words not in the right way, not correctly. And some people, I've had another client who used to miss some lines or sections of a page when reading a text. So all of this could be related to visual processing. So what type of strategies we can offer? So obviously, if the environment is cluttered, you can advise your client to reduce clutter, declutter, store object in the same place. In relation to people who tend to bump into doorways, really they can use some visual cues. For example, paint the doors and frames in a bright contrasting colors, or place colored tape on dark corners, mark edges of cabinet doors with bright tape. So again, the visual cues might help them to compensate. When it's in relation to reading, I had a client, as I mentioned, who was missing information while reading. He was using the narrator on his computer, and nowadays most computers will have this built in under ease of access. If, of course, it's a book, they can cover the text with paper or use the finger ruler, or books with larger print, and obviously using the auditory channel to compensate for the visual issues. Moving on to memory and new learning, which is something that lots of people with MS talk about. So as you can see, memory is a complex process. According to this model, as we take in input, as we take in information, it is first briefly stored as a sensory memory. If we pay enough attention, the input would move to the working memory or short-term memory. And then it is either forgotten or it is transferred to the long-term memory if we use effective processing strategies. Under long-term memory, we've got a few different memories stored there. Semantic information, so these are the concept and general information, could be visual information or procedural information. These are the skills that we've learned, such as cooking or driving. So as you can see in this model, memory relies heavily on attention and information processing. This is the encoding. And recent research suggests that memory problems experienced by people with MS actually is related to problems with attention and information processing. I'm not saying that there can't be retrieval issues. This is the word finding issues, but it is really important to remember that. So changes might look like, people would say they forget names or locations of items if they completed some task, or whether forgetting tasks that they need to be done. So this is the prospective memory, what they need to do in the future. So let's talk about intervention, and I would like actually to start with the remedial strategies that I know that people mentioned that they're not really using. So when I actually talk with a client about memory and learning issues, I actually start with identifying how they learn best, whether they're more visual learners, auditory learners, or kinesthetic. When I say kinesthetic, I mean people who learn best by actually doing, touch, movement, practice. And sometimes it could be a combination of two styles that might suit best people. I would like to demonstrate some strategies now with some of my clients. So one of my clients needed to read and remember detailed information. So first of all, what I asked her to do is to choose a time when she's feeling refreshed and alert. Really, we really need to think about fatigue. So start with that. And then I asked her to think of and actually write down some questions before she's actually going to read the text. That actually helps her to be an active reader rather than a passive reader. I also ask her to divide the long text to smaller parts, so basically chunking, and highlight or write down the keywords, which hopefully would remind her of what she has read before. So then really she just needs to read and memorize the keywords rather than the whole text. So these are all processing strategies. I've got another client moving on to remembering new procedure. So I had another client, she needed to learn a new procedure at work. She observed her colleague doing it once, but she couldn't remember it at all. So the next day I suggested my client to basically ask her colleague to show it to her again, however, more slowly, so she can write down the steps, but then practice the steps herself and ask her colleague to observe her to make sure that she's not making any mistakes. So this is what's called errorless learning. it's much better to do that rather than correcting mistakes down the track. So once my client did that, in a few days, she was able to learn the new procedure at work. Remembering names. This is something that many of my clients are telling me, I'm so frustrated, I can't remember my colleague's name, and I'm feeling so embarrassed. And I did have a client like that. So what we did is I asked her to say the name out loud and actually say what it reminds her of. So basically associate it with something that's is individual for her. So, and also associate the name with an image. So this is the combination of association with visualizing an image. And she did that. And from then on, every time a client saw her colleague, she visualized the image she created, and then she could remember the name. Now, some neuropsychologists from the Kessler Foundation have actually developed a similar technique to what I mentioned here, but much more in detail. And it was actually, it is shown to be very useful for people with not only relapsing remitting MS, but also progressive MS. And this is really important because this is a remedial strategy that actually shows that even people with progressive MS can learn new things with the right strategies. So moving on to the more compensatory strategies. Obviously, you can tell your clients that, you know, for new tasks, they do need to give themselves more time and more repetition and practice. And for the same task, basically rely on routines, so they don't need to rely on their memory. So having routines for same task, but giving themselves extra time for new tasks. And of course, using some organizational strategies, notepad, diary, organizing, calendar. Some clients of mine prefer the manual, some clients prefer electronic, and it's individual, so diaries as well. Ask your clients to have the same place for the same items and always put them there rather than delaying it. Oh, I'll put the keys later, I'll do this later. No, do it immediately after you took the item, you give it back. And you can actually help your clients to, for example, setting up a memory center if they need any help. We've mentioned here a very long list of assistive technology, mainly with apps, reminders, voice memos, speech to text. So there's lots and lots of options, and you can Google them and find out more if you haven't heard about them. I really want to have to say something to the exercise physiologists and the physios who are watching this webinar. I think it's it could be really useful if you haven't done it so far to actually film your clients on the phone when they're doing the exercises. I've seen some people actually giving, you know, exercise on a piece of paper, but then the client might lose it. So it's a really good thing that if you actually record them on a video on their phone, it will actually be there and they won't lose it, but it also would, it will actually help the client to remember how to do the exercises correctly. So I think that's a great strategy. And I've had some clients that were really struggling with learning some new software when they started working from home due to COVID-19. And what I suggested to them, I mean, they had some training sessions, but they told me it was so quick, I couldn't understand, I couldn't follow up because of reduced processing speed. So what I suggested to them is really to ask the manager or the trainer to record the sessions, to actually be able to watch it again. I even found some good YouTube videos, for example, on different software, and actually Microsoft support website has lots of good video trainings as well. So people can actually watch that at their own time and keep watching as needed. Let's move on to executive functions, just being mindful of the time. So executive functions really are like the CEO of the brain, and their role is to ensure that things get done from planning stages of the job to the final deadlines. So really it includes planning, prioritizing, organization, initiation, flexibility. So if one plan didn't work out, you have plan B. Can you be flexible in your thinking about how to do things differently? Problem solving, which is a big one. Self-monitoring, checking yourself, monitor your own performance and measure it against what was needed or what was expected. And it's also related to emotional and behavioral control, which is our ability to manage our own feelings, stopping and thinking before we actually do something. So changes in this domain would look like, basically executive functions can affect all instrumental activities of daily livings, including managing finances, being able to use transportation or driving, planning your route, shopping and meal preparation, house cleaning, home maintenance, communication, medications. So it can really be significantly affect your ability to manage well at life. So what can be done? What can we do as clinicians? And of course, it's really based on the severity of the impairment, the client's awareness, as Jackie mentioned, and also our knowledge and confidence as clinician, and the length of time that we can spend with the clients, because it really depends it depends on the setting that we see the clients in. So we really need to decide whether it's worthwhile working on practicing real-life scenarios to improve executive functions, or whether it's better to work on practicing specific tasks. So if we do have the time, let's say that the client does have good understanding, awareness, high motivation to change, and is able to learn, I would actually focus on remedial strategies. So how can we practice real-life scenarios? So I'll give you an example. Let's say that we want to improve planning organization. You can ask your client to plan a breakfast for one person, and you can ask them to write down a grocery list, and if possible, to observe them while they're actually preparing the task. A more complex task, let's say that they've mastered that, they can do that, so you can give them something a bit more difficult. So you can ask them to plan a 2-course meal, writing the grocery list while maintaining a certain budget. So you actually give some more rules to actually see how they're managing in that. So the clinician can really provide as needed guidance, such as encouraging the client to stop and plan before they actually act, before they complete the task, review the plan, reminding them to check before and after performing the task, and then evaluate their own performance to increase their awareness and learn from their experience. So what have you learned from doing that? Would you do something differently? What would you do differently? Did it actually, were you successful? So this is really the metacognition. But of course, if you really don't have much time, if you're not very confident, let's say, or the client really don't have such high motivation or not good insight, you can actually focus on repeating the most important or chosen IADLs, obviously with the client, and basically use or apply all the strategies we spoke about before, which is giving them extra time to plan, prioritize, organize, weigh the options, and encourage them to use organization strategies like checklist, to-do list, calendar organizer, taking breaks, especially if it's a complex task, and ask for help as needed. And obviously, if there's really lack of awareness and understanding, and you can always, of course, involve the family and carers as possible. I would like to wrap up our webinar today with sharing this quote from Jeffrey Gingold. He's an award-winning author of 2 books, and he wrote about his own cognitive challenges and how to manage them. So remember, we watched a video with Paula. I think what actually what stands out is that it's not easy to share vulnerable cognitive moments. And I think both Jeffrey and Paula are very brave and really need to be mindful of that when we talk with our clients when we approach, if we do have concerns, when we talk to them, when we offer interventions, we really need to be mindful of how to help them to adjust and really focus on how our intervention is going to help them to manage better. And we're really hopeful that our webinar today gave you some tools and ideas so you can help your clients to adjust to their cognitive changes. And of course, here there's some links and references to the websites and articles that we mentioned during the webinar. Thank you so much.
Thank you so much, Marley and Jackie. I have got a couple of questions. For Marley, Sue's asked, what assessments are you using to identify your next steps, your interventions?
Okay. So Sue was asking about objective assessments?
She's just got, what assessments are you using?
Okay. So actually, I'm always starting with my own observations and clients' complaints. Yes, and maybe I will be asking them some questions, as Jackie mentioned, like open-ended questions. Not so much with the carer family, but with a client. If they're still not sure, or if we do want to have a clearer understanding picture, I tend to use a lot the MOCA, because it is a cognitive screening tool, even though it's not going, it tests so many areas. It's quite easy to do, but at the same time, if there are some issues, it would pick it up quite nicely. And even with a high cognitive, high functioning clients of mine, that it does tend to pick up things. Clients that are not so really a bit concerned about doing an assessment or feel a bit more anxious, you can actually provide them with these two questionnaires, either the MSMQ, which is the most frequently used measure, or the PDQ. They're both available online, and we actually put them in the handout as well.
Beautiful. Thank you, Marley. And I think as well useful to flag to our listeners that in our 2021 webinar series, we will be doing a webinar on cognitive assessment, and we would ask in the survey if you could indicate if that is something that you would be interested in. That would be super. Also, a couple of beautiful questions as well for you, Jackie, from Jane, and also from Tricia. So a few people thinking along the same things, and that is any advice on how to start the conversation with clients who lack insight into their cognitive issue. How do you approach such a sensitive subject?
Yeah, that's a really good one. I guess it's obviously we want to make sure that they're in a comfortable space with us and a therapeutic relationship. So it's not something that I would bring up probably in my initial assessment with them, unless they were feeling quite confident about their own abilities and what was occurring. I would try and use examples of things that I'd seen in observations as well. So saying something like, I noticed that you need to write down when our next appointment is. Is that because you have difficulty remembering what's been happening? Is that a strategy that you use? It could also be asking about comments that other people have made towards them. So do other colleagues that you work with, do they think you have issues with your verbal fluency? Do they notice that you're having trouble with finding words? Or one of my clients in particular that I think about is what would your wife say in regards to that particular cognitive domain? Do you think she thinks you're reliable and on time and remembering these things that she's asking you to do? So sort of reflecting outside of their own internal domain, if that makes sense, because once you've convinced yourself that there's no issue, it's very hard to then analyze what's been going on with yourself. So looking at those external cues or providing them concrete examples of something that you've observed. So looking at assessment wise, I was in a neurology appointment last week and they asked the client to draw a clock face, which is just a really simple assessment that you you can do without training and have a look and see how they actually draw it. And he was really unable to remember the numbers on a clock face, and he was unable to remember what time she had asked him to put on the clock face after 3 or 4 reminders throughout the assessment. And that was just a really simple way of saying, well, hang on, it took me four reminders for you to get that time correct. Is that something that's happening every day? So you have to have something concrete to give them to be able to then say, is that something that we need to work on? But definitely not in your first or second assessment. It's something that you need to build up so that they trust you, that you're making good observations and good judgment as well. Anything you'd add, Marley?
No, that sounds great, Jackie.
And one of our listeners, Sue, has commented that and Sue works for MSL, just that it's important to let people with MS know that memory issues are common in MS, because some people experiencing cognitive issues are concerned that they might be getting dementia. So
absolutely. So trying to normalize that with the education side of things, saying that 50% of people with relapsing remitting MS do experience cognitive change. So it's something for them to look out for. So I've got a few clients who don't have any cognitive symptoms at the moment, but it is something that we talk about quite a lot for them to keep an eye on to see if anything does develop that we can then look at providing strategies and intervention for before it becomes an issue as well.
Okay,
it's also, I just want to add that it's nothing to do with IQ. People are really concerned that they're not as intelligent as they were before. And I found that actually for the people that their IQ was higher, like above the average, when they actually, when they notice cognitive decline, and they actually even reduce from above average to average, they still pass maybe the test, even neuropsychological test, but for them, it's a big, massive change from how they were before. So, but it has nothing to do with IQ.
Okay. And Jessica's got a specific issue. I'll read it out. I'm not sure if we're able to, how much information we're able to give, but I'll try it. So Jessica's asked, how do you manage clients whose cognitive limitations mean that they actually aren't able to follow up on recommendations to help out? For example, she developed a planner for a client who had trouble managing appointments for herself and her family, but her client forgot to print it off and just wasn't able to follow that particular recommendation.
I would like just to say one thing, and again, we might not be able to go into, because it's after 11. I think it's really important to involve the client. So maybe rather than doing it for them, ask them how would they actually would like to do that. I don't know whether, I understand why she would, for example, forget to print it off. Maybe for her, it's better to do it on the phone or having a diary rather than just a piece of paper, but really ask them the questions before we actually do it to them, making sure that they're involved in the process and they know why they do it and how they're going to do it. We can provide the guidance. I hope that is clear.
Yeah, that's great.
And I guess it depends if, yep, sorry. Go, Nicola.
I think listening to the two of you and your case studies, it reminds me you have to be creative, have that good underpinning knowledge, but there's a degree of creativity and flexibility involved, isn't there?
I was just going to say with some clients, if they are not aware of the issue, so if they don't even know that there's a difficulty with cognition, then giving them a compensatory strategy is not going to work. So that's one of the things. So instead of looking at the compensatory strategies and everything else, actually work on just building their insight is the number one key, and that's from that cognition hierarchy as well.
That's
I agree,
great.
Jackie. Starting with the education.
Yeah, thank you. I'm just trying to share my screen. So just one moment. I just want to finish off with some housekeeping for everybody, just a couple of moments. I noticed we've got one more. No, we're good with the questions. So thank you, guys. If there are any further questions, we'll follow those up separately. And sorry, that's not come up at the right place. I did have it in the right place. So I just want to run through finally some housekeeping and some information. Just also to point out that we've got client webinars in our webinar library which may be useful for your clients. For example, one's on decluttering and one's with a neuropsychologist about thinking about your thinking, which may be particularly useful for your clients. So if you go to our website, then you will be able to access those webinar recordings. And just a reminder of the huge range of services that we offer around education, NDIS, employment, and peer support, etc., which may be useful for both yourselves and your clients. We have our MS Connect service where you can access nurses and social workers and MS experts. We have the MS Practice, which is an online education tool with various subject matters for your education. As mentioned, we are an NDIS provider with different services in different areas. We have a range of podcasts for your clients, which you can access from our website and also from Spotify and Google and your podcast providers. We have ebooks, which you're eligible to access, and your username and password is there. We've got an MS shop where you can access health professional webinar recordings. We have a newsletter which has our upcoming webinars on it, and you can subscribe by calling MS Connect or through our website. And again, our number there, which is the gateway to all of our services for both health professionals and clients, 1800 042 138. And would appreciate your comments regarding the 2021 cognitive assessment webinar as well. If you can add those into the survey, that would be great. Thank you again very much for your time today. Really appreciate it. And thank you very much to Jackie and Marley for sharing their expertise today. Bye for now. Take care.